Naruhiko Ishiwada from the Chiba University, Japan. I am one of the moderators for this important online symposium. COVID-19 remains prevalent worldwide, including in Asia. We must organize the information on various aspects of COVID-19 in children and exchange the experiences and knowledge of this emerging disease between Asian countries. For all the participants, I believe that this online special symposium provides useful information for addressing COVID-19 in children. I also introduce Dr. Shu-Chi Miu from Taiwan, who will present about oxygen and respiratory treatment for COVID-19 in children.
This is a special online symposium of APPS 2021 held in Kaohsiung, Taiwan. In this session, we're going to focus on children and COVID-19. I am Professor Meizhi Zheng from Taiwan and be happy to be here with Professor Naruhiko Ishiwada from Japan to be moderators to introduce our excellent speaker, Dr. Shu-Chi Mu from Taiwan. Dr. Mu is the Chief of Education and Research Department and Pediatric Intensive Care Unit of Xinguang Wuhuoshi Medical Center in Taipei, Taiwan. Dr. Mu is an Associate Professor of School of Medicine of Furen Catholic University. And today, Dr. Mu is going to give us a very special talk in COVID-19 pandemic. The topic is oxygen and respiratory treatment for COVID-19 in children. Let's welcome Professor Mu.
Hi, have a good day. My dear friend joined APPS 2021 Congress. Welcome to listen my topic to talk about oxygen and respiratory treatment for COVID-19 in children. Let me introduce myself first. My name is Mu Shu-Chi, Dr. Mu, pediatric doctor, pediatric pulmonologist from Xinguang Memorial Hospital, Medical College, Furen Catholic University. We talk about COVID-19 disease course in children. Especially, we have to focus on second week after symptom sign onset. The tachypnea of dyspnea, the desaturation can be appeared in second week. The Arkansas Children's Hospital record high number of children hospitalization with COVID-19 in the CNN news in 2021, July 28. The Dr. Rick Barr in Arkansas Children's Hospital say the children that's of the vaccination population. So in Arkansas Children's Hospital, there are 24 pediatric patients were hospitalized with COVID-19. The up to 50% increase, the 7 are intensive care unit and 2 on ventilator is a real surge with Delta variant. Today, I will review the COVID-19 pediatric patient and review a couple articles to demonstrate here. The first one is from Italy, the second Brazil, Korea, Egypt, Colombia, India. The India is a most severe pandemic COVID-19 infection country. The last one from Canada to talk about high flow compared to conventional ventilation. The first one to talk about COVID-19 pneumonia in children, from etiology to management. The author is Giuseppe Fabio Parisi from Italy. The article demonstrates the classification of COVID-19 in children from asymptomatic to mild, moderate, severe, and critical. The moderate severe divided to the classification according to hypothalamus SpO2 less than 90 or 92 or 94%. So according to this article, they demonstrate less than 92. In children, there are mild symptom sign in children and less cases with the COVID-19 infection compared to adults. I think a lot of reasons, but one of the reasons, the ACE2 receptor, the ACE2 receptor can bind in the coronavirus spike protein in children. The ACE2 maturation and function is lower. So I think it's a major reason. Another reason could be the greater potential of the innate immune system or closer reactivity between the immune response to early childhood vaccine. About the oxygen therapy, we talk about the SpO2 less than 95% without the respiratory distress sign. The oxygen with the nasal cannula or mask constantly monitor the vital parameter. Usually, we suggest the ventilation support is a good option to use the HEPNEC CPAP. The HEPNEC CPAP with a positive end expiration of pressure up to 5 to 10 centimeter H2O. In the same section of the workshop, another speaker, my colleague, my dear friend Zhao Keyun will give a talk about the HEPNEC CPAP. The high flow nasal cannula or non-invasive ventilation CPAP, or use the which one the ventilator strategy. We have to worry about the viral particle risk on the aerosol spray. According to WHO, to use the high flow or non-invasive CPAP in single room or negative pressure room. Another article to talk about respiratory therapeutic strategy in children and adolescents with COVID-19. From Brazil, the article, the author is Lodowansky. About the respiratory strategy, the focus on original studied 6 databases. The most frequently intervention, including of the oxygen therapy, invasive mechanical ventilation, or non-invasive ventilation based on experience. About the oxygen therapy, use a nasal catheter, the most recommended strategy. Another one is a high flow nasal cannula, but we have to prevent from the dispersion of the aerosol. The most recommendation for children, we have to consider protected lung the strategy. So about the lung protected in mechanical ventilation, use the PEEP titration and use the bacteriological or viral filter. The few recommendation to use the concept of the alveolar recruitment maneuver, but it is still non-consensual. The airway suction with a closed circuit, use the prone position and do physiotherapy. It is a filter here. About the oxygen therapy, the conclusion, it is essential in the treatment of especially hypoxemia in children. The IMV should not be delayed. Use the mechanical ventilation. We have to additional consider protected lung strategy for adequate pulmonary ventilation to protect children. Another article from Korea to emphasize the alveolar recruitment maneuver, emphasize the prone position, can use any designed protocol, but it depends on children's compliance. It is a major factor. So you can design the cycle on how many hours prone, how many hours supine, do how many cycle and how many days. So another article to demonstrate a wake prone a 2 years old after intubation, the child with a severe COVID-19 pneumonitis. So design the prone position, the protocol, prone for 4 hours, supine for 1 hour, the cyclic rotation for 4 days. This article demonstrates a dramatic increase in peripheral oxygen saturation up to 97%, decreased work of breathing. Pediatric patient, it is potential adjustment for respiratory therapy, either before, during, or after invasive ventilation. A wake prone position option for COVID-19 pediatric children depends cooperation. It is a major factor to interfere the prone position effect. Another article demonstrated COVID-19 in children respiratory environment and some difference compared to adults. It is from Columbia, the best author. The oxygen therapy, according to patient evolution, so we have we can consider to use the low flow system if the children with mild hypoxemia. If the moderate to severe hypoxemia, we consider to use the high flow system. That precaution reduce the risk of dispersed contamination aerosol. Invasive mechanical ventilation, if the respiratory failure or persistent hypoxemia, the PaO2 over FiO2 less than 200, or saturation O2 over FiO2 less than 264, we can consider to give the invasive mechanical ventilation. Increase the need for oxygen or worsening tachypnea in patients on high flow nasal cannula. For children, we have to spatially consider the protected mechanical ventilation strategy. Initial parameter right here, the tidal balance set 4 to 8 cc per kilo, the low tidal volume strategy to keep the plateau pressure and up to 30 centimeter H2O. The respiratory rate according to age can set on the adequate respiratory rate. The expiration ratio set 1 to 2, and tidal PEEP, PEEP titrate according to oxygenation, arterial gases, and chest X-ray. Can increase a little bit 2 centimeter H2O if necessary. How about the FiO2? At the start, can set 100%, and in adult respiratory strategy, rapidly reduced to less than 60% in the first 2 to 6 hours. For children, we suggest stop at 60%, gradually reduced less than 40%. But according to individualized children, can give the different stopped FiO2. Another article from India to talk about respiratory care in children with COVID-19. Intubation and mechanical ventilation limit exposure the aerosol spray. The lung-protected mechanical ventilation, we have to do adequate ventilator setting to give the adequate sedation, analgesia, and neuromuscular blocker. In children with COVID-19 with respiratory distress or SpO2 less than 90%, one can give the low flow oxygen, including of the nasal prong, nasal cannula, face mask, a ventilating mask, non-rebreathing mask, bubble CPAP. The high flow oxygen spray worry about the aerosol spray, and then use a triple layer surgical mask over the nasal prong or nasal cannula. Why should we choose the high flow? The high flow the humidified heated high flow, the nasal cannula. It is a similar efficacy and safety as a nasal CPAP. The cannula nostril diameter ratio is around 0.5. It is convenient to establish a respirator support. It is friendly for clinical staff and parents. We like this. It is easier to hold a baby and the children give the high flow. It is more comfortable. The less invasive name, nasal CPAP room. There's the nose irritation. It is said high flow rate range according to age and body weight. So for example, initial setting the formula right there. For example, the flow range, for example, the 20 kilogram, the range, the flow rate 15 to 40 liter per minute. Another article to demonstrate the high flow nasal cannula compared to conventional oxygen therapy for acute hypoxemia, the respiratory failure. It is a system review and meta-analysis. This system review and meta-analysis enrolled a 12 randomized control trial. The participant 1,989 near to 1,000 patient. The high flowing patient with respiratory failure can decrease the invasive ventilation, can escalation of the oxygen therapy, and showed no difference in mortality between patients receiving high flow compared to conventional oxygen therapy. About non-invasive mode of ventilation, the high flow or NIV, mild ARDS without hemodynamic instability, we can consider to use the high flow or NIV. Closely monitor for a possible deterioration. Early intubation is important. We have to decide when to early intubate. In a single patient run with a negative pressure, use a double lumen tubing, use a viral filter at expiratory limb. Endotracheal intubation of children with worsening clinical status, early intubation is important. Prevent from the respiratory fatigue, prevent from the hemodynamic instability. But if children have with respiratory fatigue and hemodynamic intubation, we have to do endotracheal tube intubation or PaO2 over FiO2 less than 300 or change mental status. For children endotracheal intubation, we suggest video-guided laryngoscope. Prevent from the viral transmission in endotracheal intubation in negative pressure room or in single patient well ventilated room. Use the full personal protected equipment. Disposable tubing with the viral filter between the expiratory limb of the circuit machine. Limit the number of staff. We will suggest 1 to 2 people and 1 to 2 additional people outside single room or negative pressure room. The endotracheal tube intubation used the cuffed or micro-cuffed endotracheal tube. Rapid sequence induction is necessary with the muscle relaxation. Immediately inflate the cuff, connect the endotracheal tube to already set ventilator. Use the closed inside inline suction. Use the viral filter and use end-tidal CO2 detection. Do ultrasound should be used to confirm the endotracheal tube placement position is adequate. nebulization to generate aerosol, so it will suggest be avoided. The bronchodilator, if necessary to use, so we'll use the meter dose inhaler with spacer instead of nebulization. So about the take-home message, we tell a goal of oxygenation around 92 to 96%. It's a good range. About comparison of aerosol spray, we can see from the NIPPV to high flow and non-rebreathing mask. The high flow and non-rebreathing mask is the low rate of aerosol spray. So it's a good option to use a high flow and non-rebreathing mask to use the mild, moderate hypoxemia children. About the ward management protocol, keep the SpO2 over 94%, give the oxygen support, including of the nasal cannula, mask, and non-rebreathing mask, and high flow. Not recommended NIPPV because the aerosol rate is so more severe. So we have to consider and suggest the prone position if the children can cooperate. So that's my lecture finished here. Thank you for your time and attention. If any question, you can contact with me. It's my address right here. Thank you for your attention. Thank you. Bye-bye.